Hello, I'm Dr. Louis Meyers. Welcome again to Meet the Author, where I am deeply honored today to have our guest from Zoom from, I believe, Baltimore, Maryland, Dr. Leana Wen. And I'm going to take a minute to read her short, lengthy biography. Dr. Wen is a practicing emergency physician. She is a healthcare executive and one of America's leading public health experts. She is a columnist for the Washington Post, where she writes twice weekly columns on medicine and public health and anchors a newsletter. She is also a clinical associate professor at George Washington University, where she is a distinguished fellow of the Fitzhugh Mullen Institute for Health Workforce Equity. She is also a senior fellow at the Brookings Institution, the host of a executive video series, and is frequently seen on air on CNN, NPR, PBS, and the BBC. And Dr. Wen, we're very grateful to have you here in Vermont via Zoom to talk about this remarkable book, which came out some time ago, but I think is still very, very current in the issues you discuss, called Lifelines. And I want to talk first a little bit about your life, because much of that is written about in the book, the early parts of the book, and I think it informed the way you proceeded through your career and public health. It's a remarkable story. You came to the United States from your home. You were born in Shanghai, came to the United States in 1990, speaking, as you write, almost no English. Within 2 years in the United States, you were winning spelling bees. Your parents came with a total of about $40, which represented at the time a year's salary in China, but obviously in the United States did not represent a year's salary. Your mother was working on her PhD studies in Utah. And your first port of call, your first home in the United States was in Utah, where you were in a community with LDS or Mormons. Tell us a little bit about what that was like.
Well, first of all, Dr. Meyers, thank you so much for having me on your show. It's a great pleasure to be speaking with you. I've actually been reflecting a lot on this question that you mentioned regarding my move from China to the US, in part because I was almost exactly the age that my son is now, my older child is now. He's 8, and I came to the US just before I turned 8 myself. And so have been thinking through his eyes too, what if he had to change his life entirely? What would that experience be like? And that's what it was like for me. I grew up in a close-knit family in Shanghai, where I was living in an apartment with my grandparents. I saw my cousins and my aunt and uncle and the rest of my family every day. But life was difficult in China for my parents, who had political troubles. And as soon as they were able to get out, we left the country and, I think, like many immigrants, sought better opportunities. But those initial years were very hard. My mother, as you mentioned, was pursuing her studies here. That was the way that we were able to leave China. But she also had to work. She worked in a video store. She eventually became a teacher for a school district in Los Angeles, but initially was cleaning hotel rooms. My father was delivering newspapers and working in restaurants just to make ends meet. And it was hard. I mean, I think the life of many immigrants and many people of working multiple jobs, but still really struggling with basic necessities. My father had problems with ulcers, but couldn't afford his medications. We couldn't afford health insurance. We also knew many people who were in positions exactly like ours. I remember meeting people early on in my life who were neighbors and friends of the family who could not afford medications for diabetes or high blood pressure, and who thought constantly about that trade-off of, am I really sick enough to go to the doctor? How much will I have to pay? If I went to the doctor and paid for my medications, might it mean that I can't pay for rent this month? Or might I have to make a trade-off between paying for heat and paying for medicines? Which really, I mean, that early experience shaped how I understood medical care and why I wanted to become an emergency physician, because I never wanted to be in a position where I had to turn away patients because of ability to pay for their medications or for their medical care, and or because of what country they may be from, or what health insurance they may have.
And we'll talk about this in a little while, but certainly that's a very prominent issue in today's America, as it was when you came. Your mother, you write about your mother, who was a remarkable woman, and the Chinese concept of qi-ku, which I think translates into eat bitter. And that was sort of her approach to her own life, but also transmitted a bit to you. Can you talk about her influence on you?
Of course, and I also think about my mother a lot. She loved children. She decided to become a teacher, retrained in education, and I think about her because she has passed away. And she never had the chance to meet my children, who are now 5 and 8. And I look at my children, one of my kids, my daughter in particular, has facial characteristics and some personality characteristics like my mother. And I think about how much she would have really loved to meet my kids, which of course she won't have that will never happen. Um, my mother was and still is probably the hardest working person that I have ever met. She was someone also who sacrificed everything for her children. I mean, she wanted everything. She did everything and worked so hard so that my sister, my little sister, and I would have a better future. But again, not unlike many immigrant families and just moms and parents all around the world who want a better future for their children than they may have had themselves. And I would say too that growing up, I just like maybe a lot of other kids did not appreciate the many sacrifices that my parents made in coming to the US, in going through these hardships, especially in the case of my mother, who was on this fast track in academia to succeed in China as a professor, but then gave all of that up because she wanted to, again, have better opportunities for her kids, for me, and then eventually my sister in the US. Something tragic happened to my mother. When I was a second-year medical student, I remember vividly my mother telling me that she wasn't feeling well and that she had gone to see the doctor a couple of times. And that was highly unusual because my mother was someone who just sucked it up. I mean, she never talked about or complained about how tired she was or any medical illness ever. And so for her to call me and say, I think there's something wrong. I don't know what it is, but there's something wrong. That in itself was quite frightening. And I also didn't know what it was. I mean, she was tired, she was short of breath, but they were all kind of non-specific symptoms. Her doctor ran some tests, didn't know what it was. And it took basically a year from the time that she was feeling ill to the time that she was eventually diagnosed with what turned out to be metastatic breast cancer. And by then, the breast cancer had spread to her lungs, her liver, her brain, her bones. And she was about the same age that I am now. So again, something that I have been thinking a lot about as I've been thinking through what preventive tests I should be getting and so forth. And of course, she fought through her cancer. She never complained about her various treatments and how terrible they made her feel. But it was also in the course of her illness and her treatments and then going through all of that as her caregiver that I saw the disconnect that happens in our medical system between what it is that our system is doing to our patients and how patients are experiencing, in many cases, poor care. But also at the same time, I was going through my training and working with health professionals who are all trying to do the right thing. I was working with amazing nurses and physicians and techs and people across the healthcare system who were not trying to harm patients or trying to deliver a bad experience. But there was this disconnect that was happening between what was being experienced and what the intentions were. And so I think a lot of what the work that I did subsequently in patient-centered care was trying to bridge that disconnect.
You wrote a book, I think prior to this book, called When Doctors Don't Listen. And I think I would also recommend that to viewers, which can be found. How do people approach their physicians or other medical providers to make their needs and concerns heard, truly heard? Let me also just talk about your background a little bit, because it's remarkable. As I said, you barely spoke English when you came to the United States. You ended up starting college at age 13 at Cal State in Los Angeles. and then started medical school at 18, at a time when most students in the United States were just starting college. You were starting medical school. When you were in college, which was kind of a city college, you write about how it was difficult, not only as an immigrant, but as someone coming from a school that was not sort of academically nationally recognized, to think about going to medical school. But you had some important mentors, and these mentors have been important throughout your life. But can you talk a little bit about that?
Sure. And I also want to say that I do not recommend that career path, that educational path really for anyone. I mean, there might be specific circumstances that are different, but in my case, it wasn't that I was especially smart. It wasn't that I wanted to skip high school and go to college early. It was actually a financial decision. My parents were really struggling financially. By then, they also had my little sister who they could not raise here in the US because my parents had to work and there was no caregiving, another problem with our society. And they had to send her back to China to be raised with my grandparents. And in the meantime, because of their struggles financially, I wanted to help them. And one way to do so, there was a work study program at Cal State LA. I applied for that program thinking that that would allow me to work, but also you had to be a student. So that's why I also took an entrance exam to be in so that I could be in this work study program. So I think all this is to say that when I see with my children, there's no way on earth that I would want them to have a similar educational parcours. I do not want them to skip these important years of their life that are not only for their educational development, but also for their emotional development, for their just being able to play and have friends and have a normal childhood, which is something that I missed and regret. Again, their circumstances were different, but I just want to point it out there as you point this out, because I don't want the viewers to think that this is something desirable. In my case, it's really something that I did not want, but had to do because of necessity. But I'll also say that because of the background that I came from, I had no one that I could turn to as a mentor just naturally, right? I thought that I wanted to go into medical school, but because I wanted to be a doctor, because I saw people going without access to care, but I had no idea how I was actually going to do that. I didn't know doctors. My parents didn't have friends who were doctors. And I started medical, or rather, I started college thinking I am too ashamed to tell anyone that I want to go to medical school because people are going to laugh at me. They're going to think, how could you think that? What makes you think that you could even go to medical school? And I was really fortunate, as you mentioned, Dr. Myers, early in my college training, that I met a couple of incredible mentors, Dr. Garcia, Dr. Paulson, whom had me first in their work study program, right? I was working in their laboratory. I was also doing some assistant tutoring, and they started seeing something in me that I could not see in myself. And they kept on pressing me to say, what do you really want to do? We can help you get there. And I eventually said to Dr. Garcia one day that I wanted to become a physician. And he said, oh, I have previous graduates who worked in my lab also who went to medical school and who are now residents. Let me connect you with them. And it was those connections and that mentorship, the encouragement early on, that helped me see that I could do this too. And they were really instrumental. And I think that the importance of mentorship, the importance also of having those connections, those social networks that are really difficult for people who are from disadvantaged backgrounds, who are immigrants, who are people who grew up maybe in places where they don't have those connections. And it's incumbent upon us, if we really want to have a diverse workforce, if we really want to even have a workforce that understands the needs of the people that they're serving, then we have to do a lot more with creating those pipeline programs.
You, in medical school, you joined the American Medical Student Association, AMSA, and eventually became the national president. And I think took some time off, perhaps a year, to travel the country meeting with different groups of medical students. So it was really sort of your first official organizational leadership position, it sounds like, and advocacy. You were in an MD, PhD program. You decided to eventually drop the PhD part and concentrate on the MD part and the other work you were doing in advocacy. You became an emergency department physician, did your residency at Brigham and Women's, one of the premier institutions in the country. You were actually in the emergency department in Boston the day of the Boston Marathon explosions, the bombings, April of 2013. You describe that vividly in your book. What is your memory of that day?
Oh my gosh. Well, you just listed a whole bunch of things that brought back quite vivid memories too. Um, I think that that day, I was a senior resident. I was almost done with my residency, and so my entire cohort of senior residents were there. I lived in Back Bay, and which is where the bombings happened. And actually, I wasn't supposed to work in the emergency department that day. I took over the shift for someone who wasn't able to be there for some reason. And what I remember the most about that day was that my husband had said to me that because this was our last time living in Boston, we knew after that that we were moving to DC. He said, "I want to go watch the finish of the Boston Marathon because this was our last time in Boston, and he lived right in the area." Now, as it turns out, right at the last minute, he got a work phone call and wasn't able to go. And I did not know that though. And so what I remember the most from that day was as we heard the calls coming in and as we saw patient after patient coming in, some without their limbs, some who were not breathing, and many individuals had their clothes off or had injuries that made them unrecognizable. I thought, oh my gosh, what if the next person that I'm treating is actually my husband? That's my enduring memory of that day. Of course, I have many other memories too, including how all the health professionals, especially the brave EMTs, really rallied on that day, how the Boston community came together. But I think that enduring memory too is of just how so much of the work that we do is so personal. And actually referring back to what you mentioned earlier with the work that I did in advocacy, why I took the time off in medical school to advocate on behalf of medical students and physicians and most importantly the patients that we serve, it was because I saw so many problems that were happening with our healthcare system that felt so close and yet were so far. As in, these were problems with policies that were being made very far away from us that directly impacted the lives of the patients that we saw. I remember seeing this one patient who was a father of two, who was in a prolonged seizure and was in a coma because he couldn't afford his seizure medications. Because in the days before the Affordable Care Act, he had a pre-existing condition and was priced out of the ability to get health insurance. And I thought, but what am I doing here? Right? I can help this person. And of course, I'll do everything I can for this patient in front of me. But what am I doing to prevent the next person who also cannot afford their medications and now is going to be coming in because of a stroke, because of a heart attack, who may be dead because they weren't able to receive their medical care? What can I do to change those policies? And that's what led me to also work in public health, to work in policy, to try to fix those underlying problems.
Well, you did move to what national prominence as the Commissioner of Health for Baltimore, City of Baltimore. A great city, one of the great early cities in this country, which had fallen on hard times over in the 20th century. Lost population, there was a huge problem with crime in parts of Baltimore, drug addiction, et cetera, homelessness. So you took on a very challenging task. You were there for 4 years through two mayors. A number of issues you took on. One, of course, was drug addiction. The other was trying to interrupt the violence that was in Baltimore, particularly after the rioting and the death of Freddie Gray, the police encounter. Can you talk about some of the efforts you did in Baltimore and how you think that might be replicated in other parts of this country?
Sure. The work that we did around the opioid epidemic has been replicated, and I'm very proud of the work that we did together. And also, we took best practices from our counterparts around the country as well. So I'd be happy to describe that as a start. We used a three-pronged approach, recognizing that First, we have to save someone's life if they are overdosing. That's just that's imperative. And also, without saving someone's life, how are you going to be able to get them into treatment after? And so we got legislation changed on the state level that enabled me to issue a standing order, which is essentially a blanket prescription for every resident in our city to carry naloxone or Narcan, the opioid antidote. We also did trainings across our city, and within 3 years, everyday residents saved the lives of more than 3,000 other Baltimoreans from overdose. We also worked to expand treatment and started a first of its kind treatment center where individuals with mental health or addiction issues would be directed or would be diverted prior to going to the emergency department, going to the hospital. Instead, they would come to a specialized treatment center, a 24/7 behavioral health center for care. And we worked to expand treatment across the city, including in primary care settings as well. So I think that kind of model where you are helping people at the moment that they are dying, helping them connect to services, but then also getting treatment to people who want it at the time that they need it is really essential. And then you mentioned also, Dr. Myers, our work around violence prevention. We believe, and I think public health research has shown that this is the case, that violence is just like other illnesses, other contagious illnesses, something that can be prevented, something that can be treated. And there are ways to interrupt that violence. And so we hired individuals from the communities that they came from to serve as these violence interrupters at times when someone is experiencing a violent event. Perhaps they just were victims of crimes themselves. Perhaps they're involved with organizations or individuals that are perpetuating crimes, that there are ways to help to connect those individuals also to services that they may need and help them find jobs and help to interrupt the cycle of violence and trauma that often plague many of our cities.
This was I remember seeing this several years ago on national TV. This was a first of its kind too, I think, using gang members themselves to go out into the community, putting your trust in them, to go out and talk to other people who they know well, and say, look, there's a different way.
I will say this was not our innovation. Cure Violence is a national group. I believe it first started in Chicago, and they have a number of other cities that have also adopted their approach under different names. But yes, I strongly believe in that approach. Look, if you or I go into the streets of Baltimore and tell somebody, hey, you don't have to do this. You don't have to be selling drugs. You don't have to be committing crimes. You could have a job. I don't know that will be taken very seriously. But I think that it's very different when you see someone who is from the communities that they came from. Not always, but sometimes who are released from incarceration themselves, who will say, I've gone there, I've been there. There is another way. And I think that probably carries a lot more weight.
I think Baltimore is fortunately on the upswing, and I think the efforts that you started there were critical in doing that, and we hope that that will continue. In the 10 or 15 minutes we have left, I wanted to talk about COVID, because COVID came in March of 2020. I think you were still there at Baltimore. Were you still?
I was no longer the health commissioner, but I still lived in Baltimore, and I also I still live in Baltimore now. In March of 2020, I remember very well for another reason, because I was very pregnant at the time. My younger child was born in the beginning of April of 2020, and so I went through COVID, the beginning of COVID, very pregnant, and then with a young child, with a young baby, and then another young child.
And you write in the book, really the last fourth of the book, about COVID and about not only how we approached COVID, but what it meant for our public health system and why a public health system is so critical. Obviously, the United States did not do well compared to the rest of the world, much of the rest of the world. What can we do differently next time?
I think there is what we could do differently and the reality, which I think is going to be very far from that. And so I don't know if we're going to end this conversation on a particularly optimistic note, but I'll say that when it comes to public health, there's a saying that public health saved your life today. You just don't know it. That so many things we do in public health are preventing something terrible from happening. But then as a result, there is no face of that thing, right? There may be a face of a child who was lead poisoned. But what is the face of a child who could have gotten lead poisoned, but then you did home remediations and the child was fine? I mean, that there's no picture of that. Or there's the child of somebody who got sick from an infectious disease, but what is the child of someone who was vaccinated and never got that illness? And I think that in part is part of the problem that we're seeing now with the fact that many vaccine preventable diseases, people have just forgotten. They haven't seen what those diseases look like, and therefore they don't understand how safe and effective and important these vaccines might be. But I think overall that applies to public health too, that COVID really revealed how little we have invested as a country into our public health system. And in fact, we may even argue that that public health system doesn't even exist. That unlike other countries that have a robust national system, we, of course, do have national entities like the CDC or the FDA that play a part in the protection of our health and safeguarding of our health, but that are somewhat disconnected from state health departments, that local health departments are always underfunded. I mean, I always said about our work in Baltimore that it was always like robbing Peter to pay Paul, that when you have one emergency, you don't hire more people to work on that. You pull the people who are working on other emergencies to work on that. And so the same people initially working on the opioid epidemic were being pulled to work on the COVID response, or are now being pulled to work on measles. And you don't, those previous problems did not disappear, but they're just being supplanted by new issues. But we're not investing in actually addressing the problems that were there in the first place. So I think COVID laid bare that problem of the chronic underinvestment in healthcare and public health. And also it laid bare the disparities that we also saw with underrepresented communities and minority communities and rural areas and under and disadvantaged urban areas being the hardest hit in many cases, for instance. But I think in terms of what's going to happen now and what we have learned moving forward, I think we have learned we have to invest in public health. I think we have learned about the importance of establishing trust in carrying forth our recommendations. But I don't think it will be a surprise to anyone watching this, Dr. Myers, that our country is sadly more polarized, more divided, and I think, in a tougher place, such that if, God forbid, we have another horrible virus that were to hit us, I think we are less prepared and less capable of facing it. Because at least at the beginning of COVID, there was more trust in institutions. That trust has been eroded for a number of reasons. And public health hinges on trust. You're asking people to do really difficult things in some cases, in the beginning of COVID, to wear masks, to not send their kids to school, to not go to work, to forego wages, to not see your family, to not be with your loved ones even when they're very ill. I mean, it was very hard. How are we going to be able to do that again if the circumstances require it? And I fear that we are now in a place that establishing that trust is going to be much more challenging than ever before.
Just to finish, you have had mentors, and you've mentored many, many people. Elijah Cummings, a former congressman from Baltimore, was one of your great mentors and heroes, I think. He said to you, turn your pain into passion, your passion into purpose. And Fitzhugh Mullen, Dr. Fitzhugh Mullen at George Washington, a great public health advocate, was also one who said, our mission is to fight for the world as it should be. Are those statements that you carry on?
Absolutely. The idea of pain, passion, and purpose is what drives me every day. I think it is true for all of us, or at least many of us, that the most painful experiences in our lives also form the core of what drives us forward, becomes our passion, and then becomes our purpose. And for me, for example, I think about the people that I saw, the patients that I saw, whom didn't have access to healthcare, who suffered grave consequences. I think about my mother and about the many things in our lives that we miss now, about how my children will never meet my mother because of suboptimal care that she unfortunately received. Again, not the fault of an institution or a person, but just of our system overall. And those very painful experiences are certainly what drive me. And I think there is more that unites us as a people, right? We all want a future for our children that's better than the one that we may have now, than the present that we have now. We all want a future that is worth fighting for. And I hope that we'll be able to overcome our differences and see, hopefully, public health and health overall as a method that unites us.
Well, that is eloquently put. You have been fighting the good fight and are going to continue to do it, I know. We really appreciate you being here with us. The book Lifelines has so many other stories that we weren't even able to touch on, and so many other important policy statements. I recommend it, and of course your previous book, When Doctors Don't Listen. Dr. Leana Wen, thank you so much.
Thank you, Dr. Meyers.